the ovary. Okay, and so this cells they secrete this oocyte maturation inhibitor factor, which mainly arrests the first meiotic division at prophase in the diploid stage. And by puberty, number drops to about 40,000 by the beginning of the puberty. So number और कम हो जाता है puberty तक जाते जाते, and rising FSH triggers start of the ovarian cycle. And fewer than 500 ovulate in the reproductive life of the female. So proliferation, each organ again the same division. Each oogonium divides by the mitosis to form the two oogonia, and this is the mitosis division. So this is before birth, and growth. So this is during the fetal life. Growth, oogonium enlarge to form the primary oocyte and begin the primary oocyte begin the first meiotic division, but stop at the prophase. And after puberty, that first meiotic division यहाँ पर complete हो जाता है just before the ovulation. This division complete, and there is the formation of the secondary oocyte. From the primary oocyte, there is the and one polar body there is the formation of, not two secondary spermatocyte, because most of the cytoplasm it moves to the one daughter cell. So one that becomes the secondary oocyte, and other one जिसमें cytoplasm बहुत कम जाता है, that becomes the first polar body. So first polar body and the secondary oocyte. So that is the incidence that is occurring just before the ovulation. And second meiotic division start हो जाता है जैसे ही ovulation होता है due to but it is again arrested at the metaphase stage. I don't know why there is arresting of the division, so that gynecologist will deal. So this second meiotic division is completed. Secondary oocyte divides into one mature ovum. So again जब और second meiotic division तब complete होता है जब fertilization होता है. When sperm will enter into the secondary oocyte, then there is the completion of the second meiotic division. So no primary oocyte formed after the birth in the females. जितने होते हैं that is forming before the birth. So this is the stage of the first primary oocyte, primary arrested in the prophase 1 जैसे मैंने बताया before birth. उसके बाद just before the ovulation, it is again arrested still, and इसमें एक ही चीज हमें देखनी है कि साथ साथ follicle का डेवलपमेंट हो रहा है. तो this is surrounded, this primary oocyte, this is surrounded by the follicular cells which is derived from the stroma of the ovary, and this is known as the primordial follicle. So primordial follicle रहेगा before birth तक, ठीक है, and then up to the puberty, this is the primordial follicle, and when it at the puberty just before the ovulation, this primary first meiotic division जो है it finishes, and it is the formation of the secondary oocyte that was arrested in the prophase 1. So this is the growing follicle. So this is the secondary oocyte and the first polar body. और यहाँ पर follicles का size बढ़ता रहता है. So after the at the puberty, these flat cells, यहाँ पर ये जो primordial follicle, this is surrounded by the flat cells, and here these follicular cells they become cuboidal or the columnar, and this mainly forming the growing primary follicle. So here is the primordial follicle, here is the primary follicle, and these follicular cells they multiply and they form the membrana granulosa. And this membrana granulosa, this is the again growing follicle, and after that there is the formation of the cavities in this membrana granulosa, and these cavities, small cavities, they join together to form the antrum, and this is the formation of the secondary follicle. So this is primordial follicle, primary follicle, and this is the secondary follicle. So धीरे-धीरे enlarge कर रहा है follicle. Ultimately there is the formation of the Graafian follicle. See, so this was the primordial follicle. This was ये कहाँ पे था बच्चों? ये before birth. And after that there is the formation of the cuboidal cells, and this is the growing follicle, and there is the proliferation of the granulosal cells, and at this stage also there is formation of the one layer, that is the zona pellucida. This is mainly the glycoprotein which is secreted by this secondary oocyte and the granulosa cell. So this is present between the oocyte and the granulosa cell. This is the zona pellucida. So these are the stages. This is the secondary follicle. और यहाँ पर जैसे just before the ovulation, there is the formation of the first polar body. The first meiotic division that was arrested at prophase यहाँ पे complete हो जाएगा, and there is a formation of the secondary oocyte and the first polar body. And this is surrounded there is the development of a large cavity that is known as the antrum. और जो cells होती हैं which surround this oocyte, these are known as the cumulus euphoricus. I don't know how much it is important for you.
No,
it is very important.
COC is very important.
Okay. So this granulosa cell, due to this antral cavity, this granulosa cell surround this oocyte. This is known as the cumulus euphoricus, and here is the first polar body, secondary oocyte, and the cells which are attaching this oocyte to the wall of the follicle, these are known as the discus proligerus. So, and surrounding cells, they are stromal cells, they are forming the theca interna, they condense to form the theca interna, and outer there is a dense fibrous tissue which is forming the theca externa. So this is now growing second Graafian follicle, we said. So this follicle now is ready for the ovulation. This become large in size, इतना large हो जाता है कि it produces a bulge on the surface of the ovary. And वहाँ पर जब bulge बनाता है, and this theca, these cells, they become at that side जहाँ पर ये पहुँचता है at the cortex of the ovary, they form a bulge. Here the theca interna, they become thin, and these cumulus euphoricus, due to the presence of the fluid, it loosen, and this there is the process then. The process of the ovulation. So इसलिए हम ये बोलते हैं कि at the site of the ovulation there is the release of the secondary oocyte with the first polar body. So this is secondary oocyte and with the first polar body. So this is the ovulation. So at the ovulation, again this is the same diagram of the Graafian follicle which release at the ovulation. So ये आप देखो जब पूरा this is the ovary and यहाँ पर Graafian follicle. So this is producing a bulge on the surface of the ovary and ये loose हो जाते हैं, and this there is the ovulation. And after the ovulation, at the ovulation, this second meiotic division is start. यहाँ पे एकदम से second meiotic division start हो जाता है, but it again arrests at the metaphase. So मैम आप इसी stage पे So this is the stage you try the ova?
Yeah.
Okay.
Yes.
So this is the stage when the second meiotic division is start at the ovulation, but it again arrests at the metaphase. So this is important point, and this is surrounding after the ovulation, surrounding granulosa cells जो होती हैं, they are arranged radially to form the follicular cells of the corona radiata. So this is the polar body, zona pellucida is there, secondary oocyte. So this is the diagram after the ovulation. So this is in the metaphase stage, and so this is the secondary oocyte after the ovulation, जिसके साथ हम we are going dealing with in the next lectures. In the metaphase arrest हो चुका है यहाँ पर, and there is the zona pellucida. These cells arranged radially to form the corona radiata, and the cell membrane is there, zona pellucida. The spindles of the second meiotic arrested at the metaphase stage, and then the first polar body. So this was about this, and after this, when the Graafian follicle rupture, there is जो रह जाता है पीछे, that is the theca interna, granulosa cells. They may convert into the corpus luteum. Under the effect of the LH, yellow pigments form, and they ultimately form the corpus luteum if of the menstruation or the pregnancy. So if the pregnancy persists, so it will remain up to the 2 to 3 months, which secrete the progesterone. So this is the last. So now we have the secondary oocyte arrested at the metaphase stage. Second meiotic division start हो चुका है. But now when there is the entry of the sperm, then this second meiotic division finishes, and there is the formation of the second polar body. और यहाँ पर देखो, there is the formation of the female pronucleus. So now happily secondary oocyte dormant रहता है, But when sperm enter, then it happily finishes its second meiotic division, and there is a formation of the female pronucleus, and sperm, the head having the nucleus, is converted into the male pronucleus, and they are usually combined. So this Graafian follicle, this fertilization in the uterine tube. So Graafian follicle, जब rupture होता है ovulation पे, they are taken by the uterine tube. So this is the fertilization, and so this is summarizing all this spermatogenesis and oogenesis. Thank you so much. I want something to add from the gynecologist also, if you have to integrate with this.
Thank you, ma'am. Nice presentation. Candidate will benefit from this lecture. You are presenting here lots of things related to oogenesis and spermatogenesis. So I hope students will more benefit with this.
Yeah, ma'am has very nicely explained all the stages. And clinically, when we are working in the embryology lab, what we take out follicle is the cumulus oophorus complex. And we can see under the microscope the corona radiata, and it should be well dispersed. And just by looking at that picture, it looks transparent, it is transmitting light. We can grossly make out that this is a good quality matured oocyte. Then we are picking up the oocytes from the follicular fluid. So COCs are the ones which are retrieved, the oocytes, and then they are denuded and then frozen. And we'll cover the details in the coming lectures, everything. And I hope you all attend all the lectures to get a complete picture. Thank you, ma'am.
Thank you, ma'am. Now I would like to invite our second speaker of the session, respected Dr. Lajja Devi Goyal, ma'am. Photograph. Everybody. Sorry.
Ma'am, please exit.
Please, all chairpersons, please come for the group photograph of the session.
Please come in the center of the stage. Mr. Ramdayal, Dr. Manjeet Singh Sidhu has joined us. He is the president of Bathinda Oct Society and is the director and gynecologist of Creek Hospital at 100 feet road, Bathinda. Thanks for coming, sir. And sir has supported us a lot in conducting this CME, and our society, all the members of the Bathinda Oct Society are very thankful to you. And Dr. Pramod is HOD Department of Nutrition for Bangladesh. Dr. Monica, please come to the dais and hand over the certificates to the chairpersons. I would request the chairpersons to please remain on the stage. Dr. Pramod. Mr. Ramdayal.
एक मिनट सर.
Dr. Manjeet, please come. Dr. Pramod, please stay here for the group picture. Sir, please come. Dr. Manjeet. Ramdayal sir, maybe. Dr. Harpreet. Dr. Harpreet.
थोड़ा जा मैम मैडम थोड़ा जा आगे आ जाओ थोड़ा जा आगे आ जाओ एक सेकेंड
Thank you, everyone. Now I would like to invite our second speaker of the session, respected Dr. Lajja Devi Goyal ma'am, Professor and Head of Obs and Gynae Department, MD Research, AIMS Bathinda. Ma'am, please enlighten us with your lecture on fertility preservation in gynae cancers. I would like to invite our chairpersons of the session, Dr. Sandesh Ganju, Associate Professor Obs and Gynae, GGS Medical College and Hospital, Faridkot. Dr. Sanilata Goyal ma'am, MD Obs and Gynae, Goyal Hospital, Ajit Road, Bathinda. Dr. Harkiran, Dean Academics, Adesh University. Dr. Nishi Garg, MD Obs and Gynae, President Obs and Gynae Society, Kotakpura and Faridkot. I would like to invite Chairperson Dr. Sanjeev Bansal, Director Bansal Cancer Center, Bathinda.
Actually, it's my proud privilege to introduce Dr. Lajja because when she was doing her house job on the training, I was her, I can say not professor but senior at Faridkot Medical College. And at that time only, I recognized the talent in her. The hard working as she is now also, and at that time also, I used to leave the labor room entirely upon her, though she was the junior most doctor over there. Now she has achieved many things which I am still feel today in sitting here feel proud of her. She is MD, FICO, GMA, MS, Professor and Head, as you all know, of the prestigious medical college that is AIMS Bathinda. And on top of that, she is doing research also. That I came to know today only, and I really felt happy. I congratulate her for that. So, her special interest is in gynecological oncology, and that is the subject of today's her lecture. I hope all of you will gain a lot from her and her experience and her teachings. Thank you, Dr. Lajja.
Thank you, ma'am, for kind introduction. In fact, ma'am has been always very kind and encouraging for me at every step of life. And with this, I welcome you all to this conference, which is mainly organized by Dr. Rajni, but myself and Dr. Preeti are also contributing to it little bit. But Dr. Rajni has made a lot of efforts to organize this conference. So I welcome you all, and now I start my topic of fertility sparing in gynecological malignancies. As you all know that nowadays the gynecological malignancies are on rise. So many young women are coming with cancers, and once the cancer is diagnosed, they feel that life is not going to be productive for them in future. So everybody is thinking that cancer means it is a call for death. But it is not so, because there are so many cancers, if diagnosed at early stage, they can be cured without compromising even the organ. So today we are going to discuss mainly the fertility preservation. How can we retain the organs, at the same time we can have a good oncological outcome also. So my objectives will be on the discussion on cervical cancer in early stage. How can we uh, preserve the fertility in ovarian cancer and in endometrial cancer? I will be mainly concentrating on surgical procedures. I will not be discussing the oocytes preservation and ovarian preservation, uh, which will be discussed in the subsequent lectures in today's conference. So, coming to the introduction, as we know that gynecological malignancies are often diagnosed in postmenopausal age, but there is a rising trend seen in the premenopausal age group also. And the traditional management is total abdominal hysterectomy with bilateral serpingopupectomy that leads to permanent sterility in these cases. And action is very crucial. Younger than 39 is 1 in 39. It is significantly high. And in young women, the cervical cancer accounts for 2%, endometrial cancer accounts for 5%, and on the top is ovarian cancer, which accounts for around 12%. And 5-year survival rate is 46% in ovarian cancer, that is the lowest, to 80% in endometrial cancer, that is usually the highest. And overall, it is 90% in the borderline ovarian tumors. So first we will discuss the cervical cancer. The incidence is 1.5 to 14.9 per 1 lakh women in the younger age group, that is to the 20 to 49. And 45% of early cancers are usually surgically removed. And the standard management is radical hysterectomy with systemic pelvic lymphadenectomy. But in fertility sparing procedures, what we can do, if the stage is very early, we can do excisional conization of the affected area. We can do radical trachelectomy, and if it is not possible to save the uterus, we can transpose the ovaries to some other place where the future management like radiation will not affect the ovaries. So these are the NCCN guidelines which were recently published in 2022 about the fertility sparing surgery in carcinoma cervix. It is only possible to preserve the fertility in stage 1A and B. And in stage 1A, when there is no lymphovascular space invasion, the cone biopsy with negative margin is sufficient. But in stage 1A1 with LVSI and A2, you need to do radical trachelectomy with pelvic lymph node dissection. And cone biopsy, if selected, should have negative margin, but pelvic lymphadenectomy can be done with sentinel lymph node mapping or without sentinel lymph node mapping with the laparoscopy. And in stage 1B1 and 2, radical trachelectomy with pelvic and para-aortic lymph node dissection is required. These are the NCC guidelines. Now, the fertility sparing procedures, first we will discuss the conization. The excisional conization is diagnostic as well as therapeutic, because when we first get the report of cervical biopsy or it shows that there is a microinvasive carcinoma, so we plan the excisional conization, and it is indicated only in stage 1A1, and there should be no evidence of lymphovascular space, but both endocervical and curettage and the margin should be free. And this is how the excisional conization is done. We take the base at the ectocervix and the cone is removed, and the tip of the cone, the apex of the cone is in the endocervix. And Coming to the radical trachelectomy, the patient selections, the patient should undergo radical trachelectomy only if there is a strong desire to preserve the fertility. And histopathology diagnosis must be proved by expert. If if there is only one expert available, the second opinion can be taken, because it is the most important to have a correct histopathology if we are going for fertility sparing surgery. And the histopathology where it is possible only should be squamous cell carcinoma or adenosquamous carcinoma. Other carcinomas like clear carcinoma or high-grade carcinoma, the fertility sparing is not, trachelectomy is not advised. And the stage should be 1A1, 1A2 or B1 only, and tumor size should be less than 2 centimeter, and there should be preferably no evidence of pelvic or lymph node or distance metastasis. Then only it should be planned. And the preoperative assessment require colposcopy, histopathology review, I already told, and MRI. And radical trachelectomy can be done by various routes. It can be preferably should be done by vaginally, if it is not possible abdominally or laparoscopically or robotically. All the routes it is possible. Then the radical step trachelectomy, the steps are including, first we should do systemic pelvic lymphadenectomy, then excision of cervix with paracervix with 1 or 2 centimeter vagina. Upper cervical or ischemic encirclage is the most important thing, because if you don't do the encirclage, even if the patient becomes pregnant, there is a high chance of having midterm pregnancy loss. And reconstruction of the uterine carpus to the upper vagina. So these are the steps which we should do. First, the cervix is included of the vagina, and then the cartilage of the cervix are sutured with the vagina, so that there is a reconstruction of the cervical tissue into the vagina. Now, next is the fertility sparing procedure. How will you follow up? The follow-up is done. माइक लगा दो उनपे। We should do cytological examination and colposcopical examination every 3 to 4 months for first 2 years, followed by 2 years every 6 months, and yearly MRI is advised. Then what are the advantages of radical trachelectomy? There were so many literature papers in the literature which shows the radical trachelectomy versus the radical hysterectomy has same morbidity, no significant difference in intraoperative and postoperative complication, and no difference in the 5-year overall survival, disease-free survival, and progression-free survival. Now, the obstetrical outcome, although there is increased risk of second trimester miscarriage and preterm birth after the radical surgery, but there are good number of pregnancies which I will show you in the next slides. And oncological outcome, the 5-year survival rate is to the tune of 98%, and the relapse rate is very less, that is 4.5% if the patient is chosen carefully. And this is the data which I got from D. Saya, that is the very good book in gynae oncology. And this data shows that there were 96 out of 96 women who had undergone radical vaginal trachelectomy. The 61 became pregnant, and out of those, 51 had 18 patients had preterm birth, and first trimester loss was reported in 22, spontaneous abortion in 60, therapeutic abortion in 5. Second trimester loss was 12, and current pregnancy, which was ongoing at that time of trial, was 11. So these are the literature review shows that there is a radical trachelectomy has the similar prognosis as the radical hysterectomy. So it should be considered in the patients of reproductive age group who wants to preserve their fertility. It can be safely considered. There was another article which shows that abdominal radical trachelectomy has similar outcome with the as with the radical hysterectomy in early stage A1, 2 and B1. This is a summary of NCC guidelines which I have already explained to you. Now coming to the endometrial cancer. Endometrial cancer is the third most common gynecological malignancy in India. The median age of diagnosis is around 61, but incidents are rising in young women, and the standard management is abdominal hysterectomy with bilateral salpingo-oophorectomy with lymph node dissection, both pelvic and para-aortic. And the risk factor, if you know the list of risk factor, you know very young patients are at risk, who are having PCOS, obesity, infertility, nulliparity. All these are the risk factors. So more and more young women are now reporting with the endometrial cancer. So fertility preserving is becoming the talk of the day in these cases. So these are the NCC guidelines. What are the criteria we should select for preserving fertility in endometrial cancer? So the tumor should be well differentiated endometrioid carcinoma. It should be confirmed by the expert pathologist. The disease should be limited to endometrium without invading the myometrium. There should be absence of suspicious or metastatic disease on imaging like CT and MRI. Absence of lymph vascular space invasion. There should be no contraindicated to medical therapy or pregnancy. If the patient is already suffering from diabetes and uncontrolled hypertension or CAD, we should not try to preserve the fertility or organ in this case. And of course, there should be strong desire to preserve the fertility. But patient must be counseled that fertility sparing option is not a standard care of treatment for CA endometrium. So the treatment options are left with us are hormonal therapy and hysteroscopic section of focal endometrioid carcinoma, followed by levonorgestrel, IUD or oral progesterone. So there are so many guidelines like ASHRAE guidelines, ESG guidelines, which were recently published in 2022 for the fertility sparing treatment of patients with endometrial carcinoma. The guidelines suggest that combined approach consisting of hysteroscopic tumor resection followed by oral progesterone or levonorgestrel intrauterine device is the most effective fertility sparing treatment, and the level of evidence is level 2 and grade B. And GnRH releasing hormone should not be considered as the first line treatment. Now, this is the first person, that is Mason. He has described the hysteroscopical step in early endometrioid carcinoma in fertility sparing surgery. In the first step, he removed the focal tissue which were affecting the endometrium. In the second, 3 to 4 millimeter of the surrounding endometrium was removed. In the third step, 3 to 4 mm of the myometrium was also removed. So he had shown very good results with this. This was followed by, of course, progesterone therapy. And the guidelines on progesterone therapy are that which progesterone we must use. The progesterone which is used for fertility sparing in C endometrium is magistrol acetate at the dose of 160 to 320 milligram per day. This I have used in old patients also who are not fit for the surgery, and the results are very good because it will immediately arrest the bleeding. And second option is medroxyprogesterone acetate at the dose of 400 to 600 milligram per day, and it has a evidence is level 3 and grade B. And the levonorgestrel IUD is releasing 52 milligram progesterone at local site alone or in combination with oral progesterone. The level of evidence is 3, and the duration of the treatment should be minimum 6 months. So how will you follow up these patients? If you have selected the patient, you have put them on progesterone therapy. 2 consecutive endometrial biopsies showing complete response with minimal interval of 3 months are necessary to consider a success of fertility sparing treatment. And the complete response is mandatory with maintenance treatment until the pregnancy is planned. And clinical pelvic examination and ultrasonography are recommended every for 3 monthly follow-up visits in these patients. Now, what are the outcomes? The women should be encouraged Women should be encouraged to conceive as soon as the complete response is achieved. ART should be considered in order to improve the success rate and reduce the interval to conception. And natural conception may be considered in women with good reproductive potential within defined time, that is 6 to 9 months only. And maintenance therapy with IUD should be recommended to women who decline surgery after the delivery. And after the pregnancy is completed, the definite treatment should be recommended, and all those patients who are not responded, who are unable to conceive, and there is a recurrent disease or disease has progressed, and after the completion of childbearing, definite surgery is recommended. And the removal of ovary should be considered on case-by-case basis. And the other guidelines are that how will we, what is the oncological outcome? The oncological outcome is that in these patients, the studies have shown that those who have put on hormonal therapy, there is a persistent disease in about 25% patient and they require hysterectomy. The partial response is also in around 25% of the patient, and medication for additional 3 to 6 months may be considered. And there is a complete response in 50% of the patient, in which in these 50% of the cases we can encourage the fertility treatment, and recurrence rate in 15 months duration is 40%. So it is very significant. We must counsel the patient that there is almost 50% risk of having recurrence while on hormonal therapy, and the decision should be very cautious because the disease is more important than the fertility. So the successful pregnancy will significantly reduce the risk of recurrence, and IVF does not increase the risk of recurrence. So these are the NCCN guidelines. I have already explained. They have beautifully told the criteria, primary treatment and surveillance. Now coming to the ovarian cancer. Ovarian cancer is the leading cause of death from the gynecological malignancy in the Western countries. The incidence in the young age group is 1.6 to 60 per 1 lakh, and in less than 20 years it is 0.7 to 1.4 per lakh. And the standard management we all know is exploratory leptotomy followed by the frozen section of the ovarian tumor, and if invasive, TF-BSO with debulking surgery with lymph node dissection, and multiple peritoneal biopsies should be taken. And fertility preservation options. It can be considered in follicular tumors, that is the borderline ovarian tumor, epithelial ovarian tumor at stage 1A, grade 1A, in serous, mucinous and endometrioid variety only, germ cell tumors and Sertoli leading cell tumors. It is not, fertility preservation is not for clear cell, small cell and anaplastic tumor, high grade serous or mucinous or endometrioid variety, hereditary syndromes like BRCA, synchronized endometrial cancer, or if the stage of the cancer is more than stage 1. Now planning, how will you plan? If we are planning to preserve the fertility, the comprehensive surgical stage is the mainstay of conservative surgical approach, which includes removal of ipsilateral adnexa, preservation of uterus and contralateral ovary, omentectomy and multiple peritoneal biopsy, evaluation of retroperitoneal space through the pelvic and periaortic lymphadenectomy. And the indications are, when we are evaluating the tumor, it should be well differentiated. Women should be young with low parity, otherwise the pelvis should be normal. The tumor should be encapsulated and free of adhesions. There should be no invasion of capsule, lymphatics or mesovarian. Peritoneal washing must be negative, Adequate evaluation of opposite ovary should be done, and mental biopsy results should be negative. And close follow-up is possible because many of the time the patient do not come for follow-up, so we should ensure that it is possible. Excision of residual ovary should be done after the completion of the childbearing. And coming to the first tumors which are borderline, they constitute around 10 to 15% of the epithelial ovarian carcinoma and 1/3 of the ovarian cancer in the age group younger than 40. The suitable candidate they are the suitable candidate for fertility preservation because they have excellent prognosis even at advanced stage. The recurrence is 0 to 25%. It does not affect the survival rate, and the fertility preserving procedures are usually one side ovary is removed, and cystectomy is not recommended because if we do only cystectomy, there is a 40% lapse rate. Bilateral ovarian tumor, if we encounter, unilateral serpingio-ovectomy and contralateral cystectomy may be done thinking that lapse rate may be high. Routine biopsy of the contralateral healthy ovary is not recommended, and lymph node dissection is done only if the lymph nodes are enlarged or there is a peritoneal spread. And this is the data which shows the results of follow-up results of borderline malignant tumor where the conservative surgery was done. There was only 7% recurrence in 148 cases, and this was from DSAIA. And another is that how will you follow up these patients? Every 6 months for first 3 years, then yearly, and prolonged follow-up is required because they are known to have late recurrences. And oncology outcome is very good because there is a 90% survival rate. Then coming to the young germ cell tumors, the germ cell tumors arise from the primordial germ cells and derive from the embryonal gonads. The malignant germ cell tumors of the ovary are rare, accounting for only 5% of the ovarian cancer. They typically affect the young women and very aggressive in nature, and fertility sparing treatment is of paramount importance in these patients. And initial fertility sparing surgery followed by platinum based combination chemotherapy increase the survival rate to 60 to 80% even in the advanced stage in these cases. So these are very good tumors which are usually diagnosed in young age, and they are even at stage 1 when they are diagnosed, their prognosis is very good with the chemotherapy. And what we do as a fertility sparing, we do unilateral serpingio-ovectomy in select case, just stage 1 dysgerminoma stage 1A and immature teratoma stage 1A. Unilateral salpingo-ovectomy is sufficient and it is curative. No further chemotherapy is required. There is an excellent response to adjuvant chemotherapy, and it should be standard procedure. And in patient with bulky metastatic disease also, when the uterus is normal appearing and contralateral ovary is also normal, the contralateral ovary and uterus may be preserved. So this was the data on fertility sparing. This was again published in DSAIA. There were 32 patients with pure immature teratoma, and out of those, 30 patients underwent fertility sparing surgery. And of those who wanted to become pregnant, there were 7 patients, and all of them became pregnant, and most of them had of 47 months. So this is a very good study which shows the fertility outcome. Then the third type of tumors are sex cord tumors. These are the rare 4-5. They were one girl was thus married for 3 months, and she had come with a hirsutism, and she had a Leydig cell tumor. And in these cases, fertility sparing procedures like unilateral oophorectomy with peritoneal surgical staging is safe alternative to radical surgery. Lymph node dissection is not required, and further studies are required to evaluate the safety because they are very slow growing. So I think they have a very good prognosis in the future. So coming to the conclusion, the fertility sparing surgery enables the cancer patient to complete their family without compromising the oncological outcome. Patient selection and counseling are crucial in this, and further studies are required to investigate the role of fertility sparing in high-grade tumor and obstetrical outcome in rare gynecological cancers. So with this, thank you all. Any questions?
Lot of questions, I guess, on this.
Dr. Lajja,
Yes.
I'd like to ask that in your practice, how many times you have done this cancer sparing, fertility sparing surgery in cancer patients?
Ma'am, I have done in
I doubt that very few patients must be agreeing to it or willing for it.
Ma'am, I have done in 3 girls
Okay.
and 1 pregnant patient. She had come with dysgerminoma of 22 centimeter. At that time, I was in Faridkot. So she was also pregnant at pregnancy was also 20 weeks. There were lymph nodes also enlarged, but we could not remove the lymph node. We did just move the tumor, and we started chemotherapy in pregnancy. And patient had a normal delivery, and after that, she came to me with the second pregnancy also. There was no evidence of recurrence. She was going for follow-up. And there was another girl who had circumdilating cell tumor. We saved, that was in Chandigarh Medical College. We did not do a fertility sparing. We did the fertility sparing, and she, on follow-up, she conceived and she was fine. And there was another patient. She was unmarried girl. We did the fertility sparing surgery, but in that patient there was recurrence in 6 months, and the patient died of recurrence. So that patient had probably the higher stage disease, but in our pathology department we had just got that it was a stage 1A tumor, but patient had recurrence. She was 6-year-old girl. And the tumor histology was also important because it was a mixed germ cell tumor. So mixed have very bad prognosis. So that's why that patient died. And only 2 patients I remember where the pregnancy was also there after this. And CA endometrium, we had one patient of 28-year-old with PCOS. She presented with CA endometrium, but she also did not think of fertility sparing. And there were 2-3 patients who were in 25 to 31 year age. And but they had one child with CA cervix. They also did not opt for fertility sparing surgery.
Thank you.
Dr. Lajja, in patients, like we had once a patient who was referred from Command Hospital. I am discussing this case in the evening also in the case discussions. But now, since we have a senior audience in the auditorium, I would like to bring out this case. This patient had a CA adenocarcinoma of the ovary, stage 3, and her surgery was planned in 2 stages. In the first stage, her oophorectomy, right salpingo-oophorectomy, plus pelvic node dissection, para-aortic node dissection, plus omentectomy was done. The surgical staging was done in the first stage. Her left ovary was left inside. That ovary was normal. It just had a cyst, follicular cyst. So, and then the patient was referred to us. This was 3 years ago. So the patient was sent for oocyte preservation. Then we did her, like just 13 days we took. As soon as the patient came to us, we started her controlled ovarian stimulation and we preserved her embryos because she was married. And then patient went back. She received 6 cycles of chemotherapy, followed by her completion surgery, which was total abdominal hysterectomy and salpingo-oophorectomy left also. And then patient came after 1 year with a surrogate to get the embryo transferred. And the surrogate was her mother, her own mother. So this is how it was possible even in cancer ovary stage 3. When the surgery was done, and in 2 stages, after counseling everything to the patient and explaining her the risk.
What is her follow-up afterwards?
At 3 years follow-up, the patient is doing fine. Her contrast CT is done like every 6 months, and I have her reports, like there is no recurrence.
And how was it diagnosed as stage 3? Stage 3.
Stage 3 was diagnosed after the first surgery.
Where was where were the metastases? To say this is
metastasis, she had 1 liter of ascites. She had a cauliflower-like appearance in the right ovary. There were flaky deposits in the omentum also. And there were few
All the
lymph nodes.
momentum involvement.
Yes, and lymph nodes.
Usually, what I have seen must have operated around more than 600, 700 CO. No patient survived. Those who are having stage 3 or stage 4, some of them who had undergone very good surgery and chemotherapy, they will survive up to 4 or 5 years. Ultimately, there is a recurrence, and there are only 2, 3 cases which I have seen that they are surviving for 10 years after the surgery. Also, they are coming to follow up here also, which I have operated in. But overall survival in CA ovary is very bad.
You are right. So
And
we need to counsel them very well.
Yeah, we have to counsel them because life is more important than
Yes,
fertility.
yes.
And second thing is that initially they used to say, if the contralateral ovary and the uterus is normal, we can think of preserving the fertility in epithelial ovarian tumor. But nowadays the literature suggests there are occult metastases in the uterus and contralateral ovary which are not visible on naked eye appearance. So we must do TH with BS with all the high
At the
grade.
first
So
stage
60 to 70% are high grade. So high grade, I have already said that high grade ovarian epithelial tumor, the fertility sparing surgery should not be considered. And good things are that borderline tumor may be good. It is germ cell tumor, it may be good. And even like we have presented a series in Tata Memorial, my own cases of 10, 12 cases, myself and Dr. Sandesh, we have presented all the patients who are having stage 3 disease, germ cell also. All of them died, even with BEP 6 cycles. So it is, I mean, ovary is very bad. Service we can save the patient. Many patients who are having early stage service, they are almost curated with surgery. C endometrium, of course, is excellent, but ovary is very bad. In my experience of 14, 15 years, I feel that ovary should not be compromised. I mean, fertility can be compromised.
So they
in
should
the
remove
ovary.
everything in the
Yeah,
first surgery.
Yeah. First,
Okay. Thank you, ma'am.
So I guess that is why it's very important to counsel these patients for cryopreservation, preservation of ovarian tissue or embryos, because
But
fertility.
life is not there after 10 years, and the child will just. I mean, if you produce a child, leave it to somebody else. I don't think
Yeah,
how
that's
much
true, ma'am.
ethical
But
it is.
in young patients,
Yeah.
I mean, who come with very young age with the cancers, for them it is a very good option.
Yeah, good option of cryopreservation is there, but overall thinking we must counsel that your life is not that much that you can raise your child, you can see your child to the age of 25 or 30.
Now I would like to invite our chairpersons, Dr. Sandesh Kanju, Dr. Nishi Garg, Dr. Harkiran, Dr. Snehalata Goyal, and Dr. Sanjeev Bansal to the center of the stage for felicitation and a photograph.
ਅੱਗੇ ਹੋਈ ਥੋੜੇ
I invite Dr. Gandhi to please come on the stage and honor Dr. Lachha. Dr. Gandhi is Secretary, Sixth Oct and Gynae Society.
Honor to honor you.
Thanks, Dr. Gandhi. Now I invite Dr. Neela Gupta to honor our chairpersons.
ठीक है।
It was a wonderful session and Dr. Lata covered everything so nicely. And I thank all the chairpersons and the speaker of our second session.
Sir, please, Rishi. Still sending. No.
थोड़ा जग गया।
After this wonderful session, now I would like to invite third speaker of the session, that is Dr. Rajni Jindal, Director at Jindal Heart Institute and Infertility Center, Bathinda. Ma'am, please enlighten us with your session on ovarian stimulation, oocyte retrieval and vitrification. I would like to call the chairperson of the session, Dr. Neena Gupta, MD, Ops and Gynae, ART Consultant, GEM Hospital, Bathinda. Dr. Snelata Goyal, MD, Ops and Gynae, Hospital, Ajit Road, Bathinda. Dr. Anju Garg, gynecologist at Garg Multi-Speciality Hospital, Bathinda. Dr. Gargi, Secretary, Sirsa Ops and Gynae Society. And Dr. Mini Bedi, Professor, Ops and Gynae, Adesh University.
Good morning, everyone. Since we were running a little bit late, so we thought of continuing with the sessions, and we have the inauguration after this session. So it's lovely to have you all in the auditorium, and this is such an important topic that we are discussing today. And I hope everyone goes with some good take-home messages.
Good morning, everybody. It's a proud privilege to introduce our well-known speaker, Dr. Rajni Jindal. She is Consultant Assisted Reproduction, Gynae and Endoscopy at Harris Pregnancy at Jindal Heart and IVF Center, Bathinda. Now, she has an experience of 20 years in clinical practice. Her achievements you can already see on the slide, I think. She is pioneering IVF and ICSI, PGT, fertility preservation, Gynae endoscopy in the Malwa region of Punjab. She is regularly conducting CMEs and workshops for all the dissemination of medical knowledge, and she has been working very hard for this particular conference. Now, we have our esteemed speaker amongst us. Let's begin.
Thanks, Dr. Neera. It is our privilege to have Dr. Ravi Bansal, he's member Punjab Medical Council, and Dr. Tejwan Thillon, Civil Hospital and District Appropriate Authority. Sir is also in charge of our ART and Surrogacy Board. Thanks and welcome, sir, both of you. Please, we have interesting sessions, and I would request you to spend as much time as you can give to us. So coming to my lecture, so I'm going to talk on ovarian stimulation in cancer patients, oocyte retrieval and vitrification, specifically in cancer patients. So there are 4 fundamental questions that we need to address. Then we are dealing with cancer patients when somebody has come for fertility preservation and she also has cancer. So the question number 1 is it safe to stimulate these patients who have cancer? So with the new protocols that we have with us, the basic problem in these patients is we have to keep the estradiol levels to minimum. We want to get an optimum number of eggs, plus we have to keep the estradiol levels low. So we have to exercise caution when we are stimulating. Start with low doses of gonadotropins. This can be done if we are not down-regulating these patients. there are protocols in which first there is pituitary downregulation and then there is stimulation. So we have to give higher doses of gonadotropins in those patients. But in cancer patients, antagonist protocol is used where the patient is not downregulated with GnRH agonist. She is directly started with FSH and HMG, and that too in low doses like 150 IU, 100 IU, or 170 to 200 IU. So even aromatase inhibitors like letrozole and tamoxifen, these are anti-estrogens. These agents are also used in the long-term follow-up of CA breast patients, CA endometrium, CA breast. And these patients, these drugs can be added to the stimulation for 5 days, first 5 days. So they will further lower the E2 levels. Then antagonist protocol eliminates the risk of ovarian hyperstimulation, which is the most deadly side effect, iatrogenic side effect of controlled ovarian stimulation. So with an antagonist protocol, we are going to eliminate the risk of ovarian hyperstimulation, and the protocol is short also. So the patients who have come to us for fertility preservation, most of them we have been able to do within 12 to 13 days. And we could start them as soon as they decided to go for oocyte freezing. And we should avoid HCG. Human chorionic gonadotropin should be avoided at all costs, either for ovulation trigger and for luteal phase support if the patient is going for an embryo transfer. But most of the patients who have cancer, they usually just get their embryos frozen. Oocytes freezing and embryo freezing is done, then they go for the cancer treatments, they go for chemotherapy, then they come back after the cancer is treated for completing their family. So in most of these patients, embryo or oocyte is frozen. Oocyte if the patient is unmarried, and embryo if she's in a stable relationship, or if she's married, then embryo freezing is done. And when we are giving the LH surge, as we studied, Dr. Preeti taught us in the first lecture that after the LH surge, there is growth of the graphene follicle and the oocyte is released and is ready to ovulate. So for trigger in such patients, agonist, GnRH agonist like leuprolide is given and not HCG. So by taking all these precautions, we can minimize the risk of cancer worsening with our treatment. The second question is, what is the response of stimulation in these patients? So obviously patients who are diagnosed or newly diagnosed at a young age with cancer, they are under tremendous stress. Apart from the stress, they have malnourished, they have increased state of catabolism. All these things, they affect their reproductive capacity and they respond poorly to our stimulation. They even have lower AMH and low antral follicle counts when we compare them to a normal population of similar age groups. Their AMH levels and AFC counts are also low. And patients who have CA breast and they are BRCA1 mutation positive, there is association of BRCA1 mutation and poor ovarian response to stimulation. Many patients who are in the elder age group, like more than 35 years of age, and if they are poor responders, they may not produce enough oocytes, and sometimes they have to be stimulated 2 times in the same cycle. So we'll come to that in the further slides. The most important is that we cannot delay the further treatment, the definitive treatment of the patient, which could be radiotherapy, chemotherapy, or a completion surgery. So to avoid delay, we start stimulation as soon as the patient thinks that she has to preserve her fertility and she reaches the hospital. So the cycle is planned early. We all know that follicular genesis, this recent theory, it occurs in a wave-like fashion, and there are multiple follicle recruitment waves in a single menstrual cycle. And this has been proved beyond doubt in the recent years. So ovarian stimulation, it can be initiated even if she is not on her day 2 or day 3 of cycle. And dual stimulation protocols, there are protocols where we give her stimulation 2 times in the same cycle. We start in the proliferative phase, we give her gonadotropins with the antagonist protocol, we give her agonist trigger, we do her oocyte pickup, then we wait for 5 days, and after 5 days, we start another similar cycle of stimulation. Because there are many patients who will just make 1 egg or 2 eggs. Then there is no sense in freezing. For freezing, we should have at least 7, 8 oocytes. So in those patients, we can even do a dual stimulation. which would take around 28 to 30 days. A single cycle usually takes 10 to 14 days. So just a brief about the antagonist cycle. So after assessing the ovarian reserve with ultrasound, antral follicle count, AMH, and after checking the general health of the patient, she should be medically fit also. She should not have high risk factors for pregnancy in future. Gonadotropin injections, they are started and they're given daily for 5 to 7 days. After this, a follicle monitoring is done with transvaginal ultrasound scan. Gonadotropin dose is adjusted according to the response of the patient. If she has a good response, the dose can be brought lower. If she doesn't respond well, the dose can be increased. When the follicles reach a size of 13 to 14 mm, a daily antagonist injection is started to prevent a premature LH surge and follicle rupture. Because for oocyte freezing, we don't want the follicle to ovulate. It should not rupture. So we have to take it out. We have to pick it before it ruptures. Once 3 to 4 follicles reach a size of 17 to 18 mm, ovulation trigger is given with GnRH agonist for the final maturation and release of oocytes, and a transvaginal oocyte retrieval is planned 36 to 38 hours later. In dual stim, a second similar cycle of CS is initiated 5 days after oocyte retrieval. So this is a brief outline, and this is the protocol which has to be used in cancer patients. So this is just a video which is showing the equipments. So transvaginal oocyte retrieval, we need a transvaginal ultrasound scan, a TVS probe. Please go to the video, previous slide. Then we need a biopsy guide on the TVS probe. And then we need this needle. Now this is a single lumen follicle flushing needle, which is attached to an aspiration tube. And my assistant is holding a pre-warmed 15 ml test tube in her hand. So please come to the next slide. I welcome Dr. D.K. Singh, Director, AIMS, Bathinda. Welcome, sir. So all the procedures that are done for oocyte freezing, all the handling of the gametes has to be at body temperature, which is 37.2 degrees Celsius. So the follicular fluid, it is always kept at 37. Even during the processing in the lab, the stereozoom, the laminar flows are used. We keep all our reproductive tissues at 37 while handling. This is a video which shows the procedure of transvaginal oocyte retrieval. This is a stimulated ovary. We can see 6, 7 good sized follicles. Then there is an echogenic tip. We can see the needle going into the follicle. The needle goes into the center of the follicle, and we can see that the follicle is collapsing. At the same time, the fluid is collecting in the aspiration tube, and once the tube is full, it is passed into the embryology lab. And the embryologist who is handling the gametes, he will put the fluid in a petri dish, and he will take out the cumulus oophorescent complexes, COCs. Next slide. So in patients who have cancer, we have to take precautions. It has to be absolutely, disinfection is very important. For this procedure, we cannot use any disinfectant, no betadine. We have to wash the vagina nicely with almost 1 to 2 liters of normal saline, a warm normal saline wash. We cannot use betadine, which is very important. So we can't use anything which is toxic to the gametes. Now, after follicle aspiration, this is what the embryologist sees on the stereozoom. This is not the COC. The COC is denuded with hyaluronidase and mechanical pipetting. So here, we can see the polar body. This is the polar body. This is the zona pellucida, and this is the zona pellucida, the outer thinner layer, and the polar body we can see in all the oocytes. So this is an M2. This is an M2, metaphase 2 mature oocyte. So this is a good quality oocyte, and all these oocytes for patients who have come for oocyte freezing, now this is the stage. After 3 to 4 hours of incubation, they are vitrified. The patients who want to go for embryo freezing, there these oocytes, they are fertilized, denuded oocytes or pre-warmed frozen oocytes. they are always fertilized with ICSI, intracytoplasmic sperm injection. Can we go to the next slide, please? Video लगा दो, next color. So previously लगा. Yeah. So in this slide, we can see these are washed sperms which are suspended in PVP. This is a media which will reduce the motility of the sperm and we can handle them. Otherwise, they are moving at quite a rapid speed. So here you will watch that the embryologist is cutting the tail of the sperm. By cutting the tail of the sperm, he is activating the sperm and he will catch the sperm in the pipette. So he has to catch one good-looking sperm in the pipette. So, थोड़ा speed बढ़ा दो. Yeah, so this is how this goes into the injection pipette. Please show the next video. Next slide. So this video shows intracytoplasmic sperm injection. Speed बढ़ा दो थोड़ी सी. Yeah. So this is the M2 oocyte. We can see the polar body because this is a higher magnification. This is the white line membrane. And this is the injection needle with the sperm. It pierces the zona pellucida white line membrane and then it goes into the cytoplasm. And then the embryologist ensures that he is in the cytoplasm. He aspirates a little cytosol and then he injects the sperm. So for frozen oocytes, for vitrified oocytes, because they are denuded and there the zona becomes hard. So this is the method which is used for fertilizing them when the patient comes back for pregnancy after her cancer treatment. Please go to the previous slides. Now I discuss about vitrification and the different methods, just the theoretical part, because the next lectures which will deal with the vitrification media, they will deal in detail with the technique. And we are going to have a training in the evening on oocyte vitrification. And we'll be giving hands-on training to the candidates, to the delegates who have registered for the workshop. So oocyte vitrification is a very widespread technique now. With the widespread use of vitrification technique, the success rate of IVF with frozen oocytes, they are similar with the success with those of fresh oocytes. When we started vitrification, we started them with embryos. And we've been doing embryo vitrification since 2007, 2008. But that time we used to counsel the patients that we should have at least 10 to 11 oocytes, because from those the recovery rates were lower. We could get only 1 to 2 good quality after thawing. But now with the advancements of the technique and the advancements in the media, the quality, the success rate with frozen oocyte is similar to those with fresh oocytes. Now we can, with conviction, we can offer this treatment to our patients. One of the most important advancements in the ART in the last 20 years, they have happened in oocyte cryopreservation. And it has become an established procedure for both social freezing for people who are delaying family, who delay marriages, or elective. The social freezing is also called elective freezing, and even medical freezing for patients who are going for a surgery which will make them sterile, or they're going for chemotherapy or radiotherapy. So conventionally, traditionally, it was first started as slow freeze. So we know egg is the largest cell in the human body. It has a large size, it has a low surface area to volume ratio, and there's a large amount of water inside the cell. So the challenge in egg freezing was avoiding the intracellular ice formation, chilling and osmotic damage to the cell. So the vitrification, instead of slow freezing, enabled both reduction in cellular injury and higher pregnancy rates. In slow freeze, the oocytes, they are exposed to low concentration of cryoprotectants, and the procedure is very slow. The temperature is gradually removed, decreased, and they are brought to minus 200 degrees Celsius. But in vitrification, we use higher concentrations of cryoprotectants, And the cooling rates are very fast, 100 to 10,000 degrees Celsius per minute. So by vitrification technology, this is definitely a better technology, and 100% of the freezing, those are done globally now, embryo and oocyte freezing, vitrification is used. Slow freeze is now outdated for the gametes. So we've already seen this. So after freezing, I'm not touching thawing because we have Mr. Vakil with us who will be dealing with this topic. Now this is the picture of a blastocyst, and this is the last slide. We have the ART Regulatory Act with us since December 2021, and after this act, we have clear-cut guidelines as to what to be done with the stored gametes that are preserved with us in our clinics. So the guidelines clearly state that for all the patients, parents, or legal guardians who have availed this facility, they have to contact the clinic at least once in a year. They have to provide their email, they have to provide their address and intention for further preservation. Because young patients whose reproductive tissues are frozen, we don't know when they would be fit for fertility treatments. And they have to pay an annual fee at the start of the storage interval. And in case the patient does not comply, he does not contact with the clinic has to give a reminder by email or letter and keep a proof also of the same. If the patient still doesn't respond in 60 days, then the clinic is entitled to remove the tissues from storage. So this has come as a big relief because initially, before this act, young patients used to come to us for sperm freezing, and we used to be like, for how many years can I do it? Like, I can do it for short term, but then there is no guideline as to what I have to do with them later on. And then now we have clear-cut guidelines. So now this facility, we can easily counsel our patients and do it. And we should do it, we should be doing it. I think it's still lacking. The awareness amongst our faculty is lacking regarding fertility preservation. And that's why we conducted this CME. Thanks a lot.
Thank you, everybody. As we have Director Sir with us, so I would like to welcome our Director Sir. It is my great pleasure to invite our worthy Director, Professor D.K. Singh Sir, who have an immense experience in hospital management and medical education. He also worked as Director of RIMS Ranchi. As a result of his dedication, he has established 324-bedded trauma center at BHU. He was head of Department of Trauma and Emergency at AIIMS Bhopal. He has been a member of various selection committees like AIIMS, BHU, ICMR, and other medical colleges. His guidance and encouragement have been invaluable to us. His unwavering support has made this CMA successful.
So I, Dr. Preeti Chaudhary, Additional Professor and Head Department of Anatomy, hereby take this opportunity to extend a very warm welcome to our Honorable Director Sir, Professor Dr. D.K. Singh, for sparing his valuable time to grace this occasion. And Sir has always been a torch bearer and has encouraged us to organize such activities, and especially this event is this is a vision of actually Director Sir, because one of my assistant professor has done his thesis work on this area, and Sir was like of view that we should also explore in this embryology part of this part. So we should explore this area. Actually, this is his vision only. So we are we are very thankful and welcome to our Director Sir. His guidance and vision enthusiasm just to something novel to do this in this area. And due to him only, the AIIMS Bathinda has attained new heights, and we are lucky enough to have such an eminent personality with us to share his thoughts and experience. So we welcome you, sir. And I would, though MS sir is not here, he is busy in interviews. So he is so it is pleasure for me also to welcome all the senior faculty members and the dear colleagues present here of the AIIMS Bathinda and dignitaries present from other institutions also. And
I welcome everyone.
Dr. Ravi Bansal is our inspector today. He's member Punjab Medical Council. We have him with us. He is a neonatologist and pediatrician, and he has the credit of starting the first neonatal ventilation and neonatal ICU and neonatal transport facilities in our region. So he has been active in his field since 1996. I welcome you, sir. Then we have with us Dr. Tejwant Tillon. He is a civil surgeon. He is a district appropriate authority. He's dealing with a PNDT. He's also the in charge of our IART regulatory board and surrogacy board. And sir has been very cooperative. Whatever problems we have been coming since after the coming of the law, sir has been very cooperative to the patients also and to the ART clinics also. Sir, we welcome you, sir, and thanks a lot for cooperating with us. Then we have Dr. Rajesh Jindal. He is Director, Jindal Heart Institute and Infertility Center. He's a cardiologist, interventional cardiologist and electrophysiologist, and he has helped me a lot in making this event a success. Then we have Dr. Manjeet Singh Sidhu. Sir is the president of Bathinda Oct and Gynae Society. He's working tirelessly since so many years to give recognition and do for our society and bringing the gynecologists of our area together. And he always helps us whenever we want to carry some CME or workshops. Sir is always there in the forefront. Thank you, sir. Dr. Harkiran, ma'am is Dean Adesh University, and ma'am is a very dear to all of us, senior ma'am, and she's always coming for our help whenever we had some problem. Ma'am was retired HOD gynecology in Adesh Medical College. I welcome you, ma'am.
So we extend an affectionate welcome to all of you, and I would like to invite our worthy directors and all the dignitaries for the lamp lighting ceremony.
Dr. Laja, please accompany sir. Dr. Monica, Dr. Rajesh Jindal, Dr. Nishi Garg, Dr. Sandesh, Dr. Harpreet, Dr. Pramod. Dr. Pramod is a HOD forensic in Adesh Medical College. Shown a lot of interest in our meeting and we thank him for that. Dr. Suman Goel, please come on the dais. In fact, all of us can come on the dais for a picture.
Now, I would like to invite our respected director, sir, on the stage to enlighten us with some words. Director, sir. Thank you, everyone. Now, I would like to invite our respected director, sir, Professor D.K. Singh, sir, on the stage for to enlighten us with some words.
Thank you. Let me first welcome on behalf of faculty members and on behalf of AIIMS Bathinda, Dr. Ravi Bansal, who is a PMC representative, Dr. Gilo, who is the CMO, Ranjit Sidhu, President of the Gynae Society, Professor Raja Goyal, and other senior faculty members. Let me first tell you that everyone accepts that every woman have every right to have the enjoyment of motherhood, whether it is a cancer patient or cardiac patient. But at the same time, Dr. Ravi is here. We are still struggling maternal mortality. Dr. CMO साहब के पास every day must he be receiving to start the SNC in proper way. Few days back only, I read in the newspaper that 43 children died in Nanded. So we are struggling to produce one, but we are allowing, maybe I am not blaming anybody particularly, to die 43 in a day. India is a country of paradox. I will tell you my personal family experience about this. I agree that every woman has every right of motherhood, enjoy the motherhood. It is the most peaceful phase of the motherhood. As I told you that I will tell you my family experience. My daughter-in-law, in the deep COVID period, she was in Bangalore and she got pregnant. One day, she started having severe pain and she approached 40 women in Bangalore. It was great difficulty to get a vehicle, to travel, to reach the hospital. It was diagnosed as a tubal pregnancy of the right side. Next pregnancy, it was again a tubal pregnancy of the left side. I'm talking to you about the 40 women's Bangalore. And the famous gynecologist, I will not take her name, she declared her a candidate for IVF. Not to waste the time, go for IVF. We mentally prepared to go for IVF. But to contact her, it was difficult. Once she called my daughter-in-law to visit her in the hospital to fix the further procedure dates. And that day when my daughter-in-law reached to the hospital with great difficulty, and the doctor was not in good mood. She said, I'm busy today, I will not see. मेरी family members, they got agitated and they said they will not go with this gynecologist and in this hospital. They behaved very badly. Then I asked them because it was work from home. Okay, you can work from home. Meanwhile, I was trying to contact some IVF center in Delhi or in Chandigarh. I was looking for that. Meanwhile, they got a chance to visit Canada. And my sister-in-law, she is anesthesiologist in London, Ontario, Women's Hospital, Victoria, Women's and Children Hospital. Okay, you are going to Canada and going to stay in London. Why don't you take the advice of gynecologists there? I was informed that gynecologist said there is no need of IVF. Everything is normal. Just try your luck. I thought probably they do not want to increase the insurance burden. That is why वो कर रहे हैं ना, टाल रहे हैं. Personally, I had a talk with a gynecologist, few other gynecologists, not a particular gynecologist. They were knowing me. उन्होंने कहा कि ये बात होनी नहीं चाहिए. Let me try to find out the reason. Ultimately, he kept on pressuring, no, nothing is required. You go for normal things. And she got pregnant. She delivered a normal female baby. अभी जो हमारा एक्सपीरियंस है या इंफॉर्मेशन मिल रही है, yes, I will not say that this is not required. This is very much required. लेकिन इमेज ये बनती जा रही है कि ये मनी मेकिंग मशीन बनती जा रही है. I know Ashok Agarwal probably is a very famous person in the IVF circle. He is taking care of many IVF centers by fixing the rotation date and calling all prosperous women on that day to see him in that IVF center. ये impression नहीं होना चाहिए. ये होना चाहिए कि ये to help some mother, to help some woman. Helping attitude होना चाहिए. अभी जो इमेज है, बिकॉज हम लोग डॉक्टर हैं, वी आर सपोज टू हेल्प द पेशेंट. हमारी इमेज भी होनी चाहिए कि हम हेल्प कर रहे हैं. लेकिन इस आइडिया को लेके, जैसे कार्डियोलॉजिस्ट अभी इंटरवेंशन के लिए ब्रिलियंट डॉक्टर होते हुए भी बदनाम हो गए. मैं बात कार्डियोलॉजी सोसाइटी में भी कर चुका हूं, इसलिए मैं इस बात को आज आईवीएफ सोसाइटी के सामने दोहरा रहा हूं कि इमेज बिल्डिंग इज वेरी वेरी इंपॉर्टेंट. ये नहीं होना चाहिए क्योंकि मदर बनने के लिए दे आर रेडी टू गिव द प्रॉपर्टी, फुल प्रॉपर्टी. मुझे बच्चा चाहिए, हमारा सब धन ले लो, मुझे कुछ नहीं चाहिए. इस साइकिल का मिसयूज नहीं करना चाहिए. हमारा एम होना चाहिए टू हेल्प द मदर. At the same time, SNCU, NICU, PICU भी हमारे इम्प्रूव चलें और वहां हम सेवा दें. जैसे एक बर्नार्ड साहब का जो कार्डियक सर्जन थे, उनका एक स्टेटमेंट था, दिन भर मेहनत करके कार्डियक ट्रांसप्लांट किया और बहुत खुश हो गए कि पेशेंट को हमने बचा लिया. और बाहर निकला, एक अखबार पर निगाह पड़ी तो पता लगा 5 एक्सीडेंट में मारे गए. हम दिन भर मेहनत की, इतनी सिस्टम को यूज किया, इतना एक्सपेंसिव आइटम्स एक्सपेंड हुए, लेकिन रोड पर, सड़क पर 5 लोग मारे गए बिकॉज ऑफ ओवर स्पीड या रोड इंजीनियरिंग, फेलियर ऑफ रोड इंजीनियरिंग, ड्रंक एंड ड्राइविंग. सो ये हमें सोशल, टोटल ओवरऑल सोशल सिस्टम में सोचना चाहिए. मोस्टली ये गायनेकोलॉजिस्ट जो आईवीएफ सेंटर्स चला रहे हैं, उनको मनी मेकिंग मशीन की तरह सोचा जा रहा है. उसका प्रोसेस में थोड़ा मुझे इंफॉर्मेशन है. उनको कुछ भी ना आता हो जो ये सेंटर चला रहे हैं. देयर आर पीपल वो घूम घूम के करते हैं हायर बेसिस पर. ये सब इमेज बिल्डिंग पर प्रोसेस हुई है, सबकी रिस्पॉन्सिबिलिटी है। एम्स के इस कैंपस में आई विल आल्सो रिक्वेस्ट HOD गायनी to start the IVF center as soon as possible. There are many problems, space problem to faculty problem. But at the same time, I am requesting you all the gynecologists, means those who are trying to start the IVF center, to care about that, their image also. Thank you very much. Sorry if I have spoken anything wrong, but this is my personal view.
Thank you, sir, for sparing your valuable time and sharing your words of wisdom with us. Now, I would like to invite Dr. Lajja Devi Goyal, Dr. Preeti Chaudhary, and Dr. Rajni Jindal on stage to felicitate our worthy directors.
मैडम
एक इंदिरा IVF से KM हॉस्पिटल से शुरू हुआ और 200 इंदिरा IVF।
मैडम सामने
उनका बजट मैक्सिमम IVF कर रहे हैं। अशोक अग्रवाल जिनका मैंने नाम दिया, वो MSc जूलॉजी।
से बहुत अच्छी डॉक्टर आपने चाहिए।
वही कर रहे हैं कि 40 बच्चे मर जा रहे हैं और हमें पैदा करने के लिए करोड़ों खर्च कर रहे हैं।
सर, नए रूल्स आने के बाद चीजें बेटर होंगी। अभी दिसंबर 2020 में भी आया है, तो इसमें सब मैन पावर एंड एवरीथिंग ऑन कर सकता है।
वही इसीलिए मैंने घर का एक्सपीरियंस पिछले साल का ही बताया।
डॉक्टर ज्यादा प्रिफर है आपके यहीं
अनाउंस करेंगे।
Now I would like to invite Dr. Lajja Devi Goyal, Preeti ma'am, and Rajni ma'am to felicitate Dr. Tejwan Negro. And Dr. Ravi Bansal sir. Thank you, sir. Now I would like to invite Dr. Rajni Kaur ma'am, Assistant Professor, Department of Obs and Gynae, for a vote of thanks.
I invite Dr. Ravi, our member from the Punjab Medical Council, for a speech.
Our very respectable Dr. D.K. Singh, Director AIMS, Dr. Tejwant, Civil Surgeon Freeport, Dr. Laja, Dr. Nishigar, and Bathinda Obstetric and Gynae Society. I convey my sincere regards to all of you and very good morning. मैंने अभी डॉक्टर साहब की बात सुनी एज बिल्डिंग की, तो ये सिर्फ आईवीएफ में नहीं है सर, ये एक्चुअली सारे डॉक्टर्स का है। मैं आपको अपना एक्सपीरियंस बताता हूँ पंजाब मेडिकल काउंसिल का, कि एक महीने में कम से कम 300 से 500 एप्लीकेशंस अगेंस्ट डॉक्टर्स आ रही हैं हमारे पास, अगेंस्ट फ्रॉम द प्राइवेट सेक्टर, फ्रॉम द गवर्नमेंट सेक्टर एंड फ्रॉम द मेडिकल कॉलेज। तो ये सिर्फ आईवीएफ का या कार्डियोलॉजिस्ट का नहीं है, ये तकरीबन होल सोसाइटी का है। और लोगों का बिहेवियर इज चेंजिंग अ लॉट, क्योंकि लोगों का टेम्परमेंट और पेशेंस बड़ी कम हो गई है। पर मैं आपको आज की जो कॉन्फ्रेंस थी, जो मैडम है डॉक्टर रजनी जिंदल, इनके बारे में मैं बड़ी कॉन्फिडेंस और अथॉरिटी से बोल सकता हूँ कि शी इज वन ऑफ द मोस्ट एथिकल आईवीएफ प्रैक्टिशनर ऑफ द होल रीजन। हमारे लोग जब भी मेरे पास आते हैं, मुक्तसर में आईवीएफ शुरू हुआ, मोगा में शुरू हुआ, या पंजाब के और डिफरेंट पार्ट से, शी इज द मेंटर ऑफ मोस्ट ऑफ द पीपल। और जो आपने कार्डियोलॉजिस्ट की बात की, हमारे कोर्ट पर से जितने भी बंदे जाते हैं कि यार डॉक्टर जिंदल को ले जाओ, वो एक्चुअली बातों के स्ट्रेटजी तो उनका इधर ही है, एंड ही इज द मोस्ट कॉम्पिटेंट, बोथ कपल इज द मोस्ट एथिकल पीपल ऑफ द आवर रीजन। So I congratulate you all of you, and सबसे इम्पोर्टेंट बात जो आपने बोला कि आपकी बात सुन के मेरे को है कि आप कहीं 40s में और उनका मूड खराब था। ऐसे ही मेरे को 6 साल पहले ना जी एक गायनेकोलॉजिस्ट की कंप्लेंट हो गई, तो हम डीसी साहब के पास गए। वो बोलते कि चलो जी आप चलो, आपके दोस्त हैं तो आप मेरे साथ चलो। तो वहाँ पे कंप्लेंट थी कि बिहेवियर बड़ा अच्छा नहीं है डॉक्टर का। तो ऐसे कुछ ने 2-3 चीजें और रही थी। तो मैं डीसी साहब ने क्या, मैं कहा डीसी साहब ये एक्चुअली गायनेकोलॉजिस्ट में रात को हर रोज 2-2 3 मरीज आते हैं, और जो भी पेशेंट है उनका दिमाग में चलता रहता है। They raise their children, they take care of their families, they take care of their house as well as their profession. तो इनको तो आप बहुत ही पॉजिटिव निगाह से देखो, ये ऐसे नहीं चलता। आप 2 बार जाके देखो, फिर आपको पता चलेगा कि रात को जागना कैसे होता है। और उसका मेरे को 1 महीने के बाद फोन आया एक बार, कहता यार मैंने ना 2 बड़ी जागना पड़ गया पिछले 2 दिन से, इसलिए मेरे को सीवियर माइग्रेन हो रहा है। कहता तेरी बात ही थी यार। तो मैंने कहा इसलिए ये बड़ी भारी शक्ति है, तो इसको पूरा ध्यान से पॉजिटिव वे से देखना चाहिए। सो अगेन आई कांग्रेचुलेट ऑल द मेंबर्स ऑफ बठिंडा ऑब्स्टेट्रिक सोसाइटी टू कंडक्ट अ वंडरफुल कॉन्फ्रेंस। बट एक मेरी छोटी सी सजेशन है टू द ऑर्गेनाइजर्स, इट्स बेटर टू कीप सच मीटिंग्स ऑन संडे, क्योंकि आज मेरे को बहुत सारे गाइनिक्स का पता चला कि वो उनको इनविटेशन था नहीं, या उन लोगों को आज ऊपरी होने की वजह से वो लोग अटेंड नहीं कर सके। बिकॉज ये कॉन्फ्रेंस बड़ी अच्छी है, बड़ी इंफॉर्मेटिव है, एंड दिस बेनिफिट शुड पास ऑन टू मोस्ट ऑफ द पीपल। थैंक यू वेरी मच।
Thank you so much, sir, for your worthy words. Now, I would like to invite Dr. Bathinda Oct, Assistant Professor, Department of Opt and Gynae, Bathinda, for a word of thanks.
Thank you, Shikha. Good afternoon, everyone. I take this honor to deliver the vote of thanks. We have the gracious presence of eminent personalities of the region. I express my sincere thanks to Dr. D.K. Singh, Director AIMS, Dr. Ravi Bansal, a renowned pediatrician from Kotkapura and member BMC, Dr. Tejwant Singh Tillo, Civil Surgeon Bathinda, Dr. Manjeet Singh Sidhu, President Bathinda Oct and Gynae Society, Dr. Rajesh Jindal, renowned cardiologist from Bathinda. Desired results can be achieved if you surround yourself with people of diverse perspectives who can guide us, correct us, and motivate us. And this holds true for a very dynamic organizing chairpersons of today's CME, Dr. Laja Devi Goyal, Dr. Preeti Chaudhary, and Dr. Rajni Jindal. I express my sincere gratitude to them for designing this CME and workshop so meticulously that all the important topics will be covered. My heartfelt gratitude and thanks to the eminent speakers and experts, chairpersons of the sessions, for sharing their knowledge and experience about the chosen topics. I would like to thank the members of the organizing committee who have been working tirelessly for the smooth conduct of the CME. I'm thankful to all the delegates who have come from different regions of the state to make this day a success. Thank you everyone.
Thank you, Gurpreet ma'am. Now we'll proceed for Heidi.
डॉक्टर्स ने गायनेकोलॉजिस्ट ने इस चीज़ को कवर किया है क्योंकि बहुत सारी टेक्निक ऐसियां ने जिसके नाल बांझपन ਨੂੰ खत्म किया जा सकता है ना बच्चा होने के जोड़े ਨੂੰ बच्चे की प्राप्ति की जा सकती है जिस तरह के IVF के नाल ये कोई गलत तरीका नहीं है ये सिर्फ ओवरकम करते हैं जिस प्रॉब्लम्स करके बच्चा नहीं हो रहा होता ਅਸੀਂ ਉਹਨੂੰ ओवरकम करके बच्चा दे सकते हैं दूसरी गल जो कैंसर है वो अजकल समहाउ दैट बड़ा कॉमन हो गया छोटी उम्र में भी होना पहला छोटी उम्र में कैंसर नहीं सी होता तुम ये कह लो कि इन्वायरमेंट चेंज कारण या खाने कारण ਅਸੀਂ देखते हैं कि छोटी उम्र के 28 साल 30-35 के अंदर अंदर भी कई बार पेशेंट कैंसर ਨਾਲ पीड़ित हो जाते हैं उस हालत ਦੇ ਵਿੱਚ ਉਹਨਾਂ ਦੀ ਜਿਹੜੀ ਬੇਅਮੀਦੀ ਹੁੰਦੀ ਹੈ ਕਿ ਹੁਣ ਅਸੀਂ ਮਾਂ ਬਣ ਹੀ ਨਹੀਂ ਸਕਾਂਗੇ ਉਸ ਨੂੰ ਕੁਝ ਹੱਦ ਤੱਕ ਡਾਕਟਰਸ ਨੇ ਓਵਰਕਮ ਕਰਨ ਦੀ ਕੋਸ਼ਿਸ਼ ਕੀਤੀ ਹੈ ਤਾਂ ਕਿ ਲੇਟਰ ਆਨ ਮਾਂ ਬਣ ਸਕੇ ਕਿਉਂਕਿ ਮਾਂ ਬਣਨਾ ਹਰ ਔਰਤ ਦਾ ਇੱਕ ਸੁਪਨਾ ਹੁੰਦਾ
ਕਿੱਦਾਂ ਲੱਗਾ ਤੁਹਾਨੂੰ ਅੱਜ ਤੁਸੀਂ ਮਤਲਬ ਪੁਰਾਣੇ ਗੈਨਕੋਲੋਜਿਸਟ ਹੋ ਲੰਬਾ ਤਜਰਬਾ ਕਿੱਦਾਂ ਲੱਗਾ ਤੁਹਾਨੂੰ ਅੱਜ ਦਾ ਸੈਮੀਨਾਰ ਜਿਹਦੇ ਵਿੱਚ ਯੰਗ ਬਲੱਡਰ ਸਾਡੇ ਸਟੂਡੈਂਟਸ ਜਿਹੜੇ ਏਮਸ ਦੇ ਉਹ ਵੀ ਆਏ ਉਹਨਾਂ ਨੇ ਵੀ ਬੜੀ ਉਹਨਾਂ ਨੂੰ ਇਨਫੋਰਮੇਸ਼ਨ ਇਸ ਚੀਜ਼ ਦੀ ਕਿਉਂਕਿ ਜਦੋਂ ਕੈਂਸਰ ਹੋ ਜਾਂਦਾ ਬੰਦੇ ਨੂੰ ਇਹ ਲੱਗਦਾ ਵੀ ਮੇਰੀ ਜ਼ਿੰਦਗੀ ਐਂਡ ਹੈ ਪਰ ਜਿੱਦਾਂ ਬੱਚੇ ਦਾ ਹੋਣਾ ਔਰ ਜਿਸ ਤਰੀਕੇ ਨਾਲ ਇਹਨੇ ਦੱਸਿਆ ਕਿ 10 ਸਾਲ ਤੱਕ ਕਈਆਂ ਦੀ ਇਹ ਲਾਈਫ ਹੁੰਦੀ ਹੈਗੀ ਆ ਉਹਨਾਂ ਨੂੰ ਇਦਾਂ ਕਰਨਾ ਚਾਹੀਦਾ ਇਹਦੇ ਨਾਲ ਕਾਫੀ ਅਵੇਅਰਨੈਸ ਡਾਕਟਰਸ ਨੂੰ ਗੈਨਕੋਲੋਜਿਸਟ ਨੂੰ ਮਿਲੀ ਹੈ
ਬਹੁਤ ਜ਼ਿਆਦਾ ਸੇਧ ਮਿਲੀ ਹੈ ਕਿਉਂਕਿ ਜਿਹੜੇ ਬੱਚੇ ਹਲੇ ਸਿੱਖ ਰਹੇ ਆ ਇਸ ਫੀਲਡ 'ਚ ਆ ਰਹੇ ਉਹਨਾਂ ਦੇ ਦਿਮਾਗ 'ਚ ਹੁਣ ਇਸ ਪਾਸੇ ਇਹ ਸੋਚਣਾ ਸ਼ੁਰੂ ਹੋ ਗਿਆ ਕਿ ਕਿਵੇਂ ਅਸੀਂ ਕੈਂਸਰ ਪੀੜਤ ਬੰਦੇ ਬੱਚੇ ਨੂੰ ਵੀ ਜਾਂ ਕੈਂਸਰ ਪੀੜਤ ਔਰਤ ਨੂੰ ਵੀ ਇੱਕ ਮਾਂ ਬਣਨ ਦਾ ਸੁਪਨਾ ਪੂਰਾ ਕਰ ਸਕਦੇ ਹਾਂ ਅੱਜ ਦੇ ਸੈਮੀਨਾਰ ਦੇ ਵਿੱਚ ਬੜੀ ਡਿਟੇਲ ਦੇ ਵਿੱਚ ਦੱਸਿਆ ਗਿਆ ਡਾਕਟਰ ਲੱਜਾ ਵੱਲੋਂ ਰਜਨੀ ਵੱਲੋਂ ਇਹਨਾਂ ਦੋਨੋਂ ਟੌਪਿਕਸ ਤੇ ਡਾਕਟਰ ਲੱਜਾ ਨੇ ਦੱਸਿਆ ਕਿ ਕਿਸ ਤਰ੍ਹਾਂ ਸਰਜਰੀ ਕਰਕੇ ਅਸੀਂ ਮੋਡੀਫਾਈ ਕਰ ਸਕਦੇ ਹਾਂ ਤਾਂ ਕਿ ਲੇਟਰ ਆਨ ਬੱਚਾ ਪੈਦਾ ਹੋ ਸਕੇ ਹਰ ਇੱਕ ਕੈਂਸਰ ਨੂੰ ਇੱਕ ਇੱਕ ਕਰਕੇ ਉਹਨਾਂ ਨੇ ਬੱਚੇਦਾਨੀ ਦੇ ਮੂੰਹ ਦਾ ਜਾਂ ਅੰਡੇਦਾਨੀ ਦਾ ਕੈਂਸਰ ਦੀ ਵੇ ਆਊਟ ਦੱਸਿਆ ਕਿ ਕੈਂਸਰ ਤੋਂ ਬਾਅਦ ਵੀ ਬੱਚਾ ਹੋ ਸਕੇ ਇਸੇ ਤਰ੍ਹਾਂ ਡਾਕਟਰ ਰਜਨੀ ਨੇ ਸਾਨੂੰ ਇਹ ਵੀ ਉਮੀਦਾਂ ਦਿੱਤੀਆਂ ਨੇ ਕਿ ਭਾਵੇਂ ਬੱਚਾ 10 ਸਾਲ ਬਾਅਦ ਵੀ ਲੈਣਾ ਹੋਵੇ ਤਾਂ ਵੀ ਬੱਚਾ ਹੋ ਸਕਦਾ ਸੋ ਦੈਟ 10 ਸਾਲ ਦੇ ਵਿੱਚ ਉਹਨੇ ਆਪਣੀ ਟ੍ਰੀਟਮੈਂਟ ਕਰਾਉਣੀ ਹੈ ਜਾਂ ਕਿਸੇ ਕਾਰਨ ਕਰਕੇ ਸੋ ਇਹ ਬੜੇ ਨਵੇਂ ਮੈਥਡ ਨੇ ਆਈ ਥਿੰਕ ਸਾਰੇ ਡਾਕਟਰਸ ਨੂੰ ਨਾਟ ਓਨਲੀ ਡਾਕਟਰਸ ਬਟ ਪਬਲਿਕ ਨੂੰ ਵੀ ਅਵੇਅਰ ਹੋਣਾ ਚਾਹੀਦਾ ਕਿ ਇਹ ਤਰੀਕੇ ਹੈਗੇ ਨੇ ਬੱਚਾ ਹੁੰਦੇ ਜੇ ਕੈਂਸਰ ਵੀ ਹੋ ਜਾਏ ਤਾਂ ਵੀ ਉਮੀਦ ਹੁੰਦੀ
ਅੱਜ ਆਪਾਂ ਦੇਖ ਰਹੇ ਹਾਂ ਕਿ ਹਾਈ ਜਿਹੜੇ ਉਹ ਡਾਕਟਰ ਜਿਹੜੇ ਇਹਨਾਂ ਨੂੰ ਆਪਾਂ ਘੰਟੇ ਵੇਟ ਕਰਨੀ ਪੈਂਦੀ ਹੈਗੀ ਆ ਉਹਨਾਂ ਦੀ ਲਾਈਫ ਸਪੀਚ ਜਿਹੜੀ ਹੈਗੀ ਤੁਸੀਂ ਦੇਖ ਰਹੇ ਹੋ ਡਾਕਟਰ ਸਾਹਿਬ ਸੁਣ ਰਹੇ ਹੋ ਔਰ ਇੱਕ ਏਮਸ ਦੇ ਦਾ ਬਹੁਤ ਵੱਡਾ ਉਪਰਾਲਾ ਹੈਗਾ ਡਾਕਟਰ ਜੀ ਨੇ ਜੋ ਉਹਨਾਂ ਨਾਲ ਮਿਲ ਕੇ ਕੀਤਾ ਹੈਗਾ ਜਿਸ ਦੇ ਵਿੱਚ ਆਪਾਂ ਦੇਖ ਸਕਦੇ ਹਾਂ ਕਿ ਕਾਫੀ ਡਾਕਟਰਸ ਦੇ ਜਿਹੜੇ ਹੈਗੇ ਆ ਇੱਕ ਪ੍ਰੈਕਟਿਸ ਸੀਗੀ ਉਹਨਾਂ ਲੋਕਾਂ ਦੇ ਨਾਲ ਜੋ ਬੱਚੇ ਵੀ ਜਿਹੜੇ ਹੈਗੇ ਮੈਡੀਕਲ ਕਾਲਜ ਦੇ ਵਿੱਚ ਪ੍ਰਾਈਵੇਟ ਸੀਗੇ ਆਪਾਂ ਆਲਾ ਦੇਖਦੇ ਹਾਂ
प्लेटफॉर्म दिता एंड डीके सर ने बहुत कोऑपरेट करते हैं। तो जो बठिंडा एसोसीएशन ने मैडम रजनी ने जो इनिशिएटिव लैके एक खास इनिशिएटिव क्योंकि एक जी नॉलेज है पेशेंट को बहुत शेयर करनी भी जरूरी है, डॉक्टर्स को भी अपडेट रहना अजकल के जमाने बहुत जरूरी है। बड़िया चेंजेस आ रही हैं जिस हिसाब नाल चल रहा। सो ये बड़ी इन्फॉर्मेटिव नॉलेज है भी कितने पेशेंट को कहना चाहिए भी तुसी आपकी प्रेगनेंसी वास्ते जाओ जिते कैंसर है, कितने नहीं जाना चाहिए। सो कितने होनी है तो उन्होंने की एडवाइस करनी है, इस बड़ी इन्फॉर्मेशन गैदर की है जो मैं लगता होर भी अगे जाके लैक्चर है। इस इन्फॉर्मेशन बहुत जो बठिंडे के डॉक्टर कि बठिंडे डॉक्टर तो अगे लोगों को बहुत सहायता मिलूगी, जो कि कई बार लोगों को पता नहीं लगता सी की करिए कितने जाके जाइए। सो ये उन्होंने जो दुविधा ने उन्होंने दूर करनी तो बहुत हेल्पफुल होगी।
सर की कहना चाहोगे कि हम साढ़े को बहुत ही ईमानदार सरकार आई है जी कि प्रैशर रहता है, तुम एज ए सिविल सर्जन सेवा कर रहे हो और ये बड़ा एक पॉजिटिविटी है साढ़े पंजाब वासियों के लिए कि सानू ऐसा जरा सीएम मिले जरा कि हमेशा हैल्थ के ऊपर एम्फसाइज करता, स्टडी के ऊपर एम्फसाइज करता है और काफ़ी वड्डियां चेंजेस ने क्योंकि अगे प्रैशर चाहे आप जितना मर्जी कही जाइए सिविल सर्जनों का भी प्रैशर सीगा और हम जो प्रैशर रिलीज है और बिल्कुल फ्रीली तुम अपना सेवा कर रहे हो और वो सेवा करनी ये है कि मैडिकल जो फैसिलिटीज का लोगों बहुत वधिया मिले।
मेन प्रायोरिटी देखो जी जो सरकार आई है हैल्थ रही है, हैल्थ के वधिया सहूलतां ही बहुत वधिया लोगों को फैसिलिटी हैगी है। ये सरकार का बेसिकली बड़ा प्रैशर भी इन्ना सानू एडमिशन का तालमेल हायर लैवल तालमेल जोड़ा असी देखो मेरी 32 साल की जीवन सर्विस हो गई, असी नहीं देखा सी कितने PSCs के पैसे लगते CSC के पैसे लगते, उन्होंने अदारिया ने उन्होंने अपलिफ्ट किया पैसे लग के उत्थे अज एयर कंडीशन अवेलेबल ने, लोग बैठते आराम नाल बैठे ने उन्होंने। सो उन्होंने ट्रांसफॉर्मेशन जो हम सैकेंडरी जो अगला स्टैप है इन्होंने प्राइमरी किया, हूँ जोड़े सैकेंडरी डिस्ट्रिक्ट हॉस्पिटल अपलिफ्ट कर रहे हैं जिन्हें अभी प्रपोजल भेज चुके हैं। सो सरकार का बहुत वधिया इनिशिएटिव है। ये हैल्थ है जो कि हर आम आदमी को लोड़ पैंदी है, इस दी सेहत सहूलतां बहुत बैटर हो गई।
सर बहुत बहुत धन्यवाद तुहाडा समय।
ਬਹੁਤ ਸਾਰੇ ਲੋਕ ਇਹਨੂੰ ਅਫੋਰਡ ਵੀ ਨਹੀਂ ਕਰਦੇ। ਤੇ ਜਿਵੇਂ ਆਪਾਂ ਡਾਇਰੈਕਟਰ ਸਾਹਿਬ ਨੂੰ ਵੀ ਸੁਣਿਆ, ਉਹਨਾਂ ਨੂੰ ਵੀ ਐਂ ਲੱਗਦਾ ਕਿ ਸ਼ਾਇਦ IVF ਡਾਕਟਰਸ ਜ਼ਿਆਦਾ ਅਨਐਥੀਕਲ ਪ੍ਰੈਕਟਿਸ ਕਰਦੇ ਆ ਜਾਂ ਹਰ ਕਿਸੇ ਨੂੰ ਹੀ IVF ਐਡਵਾਈਸ ਕਰ ਦਿੰਦੇ ਆ। ਤਾਂ ਜਦੋਂ ਗਵਰਨਮੈਂਟ ਸੈਕਟਰ 'ਚ ਵੀ ਫੈਸਿਲਿਟੀ ਅਵੇਲੇਬਲ ਹੋ ਜਾਏਗੀ ਤੇ ਪੇਸ਼ੈਂਟ ਉੱਥੇ ਵੀ ਜਾਏਗਾ, ਉੱਥੋਂ ਦੇ ਡਾਕਟਰ ਵੀ ਉਹਨੂੰ ਦੇਖਣਗੇ, ਫਿਰ ਉਹਨੂੰ ਉਹ ਕੁਛ ਐਡਵਾਈਸ ਦੇਣਗੇ, ਉਹਨੂੰ ਇੱਕ ਸੈਕਿੰਡ ਓਪੀਨੀਅਨ ਮਿਲੇਗਾ ਕਿ ਉਹਦੇ ਲਈ ਕੀ ਟ੍ਰੀਟਮੈਂਟ ਬੈਸਟ ਹੈ। ਫਿਰ ਉਹ ਉਸ ਤੋਂ ਬਾਅਦ ਜਦੋਂ ਪ੍ਰਾਈਵੇਟ 'ਚ ਆਏਗਾ ਤਾਂ ਉਹ ਜ਼ਿਆਦਾ ਫੇਥ ਨਾਲ ਆਏਗਾ, ਜ਼ਿਆਦਾ ਟਰਸਟ ਨਾਲ ਆਏਗਾ। ਤਾਂ ਬਹੁਤ ਜ਼ਰੂਰੀ ਹੈ ਕਿ ਆਪਾਂ ਆਪਣੇ ਸਰਕਾਰੀ ਹਸਪੀਟਲਸ 'ਚ ਵੀ ਹੈਲਪ ਕਰੀਏ ਕਿ ਇਹ ਲੈਬਸ ਲੱਗਣ, IVF ਸ਼ੁਰੂ ਹੋਵੇ, ਐਂਡਰੋਲੋਜੀ ਸ਼ੁਰੂ ਹੋਵੇ, ART ਬੈਂਕਸ ਸ਼ੁਰੂ ਹੋਣ। ਕਿਉਂਕਿ ਹੁਣ ਪ੍ਰੈਕਟੀਕਲੀ ਗਵਰਨਮੈਂਟ ਸੈਕਟਰ 'ਚ ਚੀਜ਼ ਨਹੀਂ ਹੋਣ ਕਰਕੇ ART ਬੈਂਕਸ ਦੇ ਰਨਿੰਗ ਦੀ ਪ੍ਰੋਬਲਮ ਬਹੁਤ ਵੱਡੀ ਬਣੀ ਪਈ ਹੈ। ART ਬੈਂਕਸ ਪ੍ਰਾਈਵੇਟ ਖੁੱਲ੍ਹ ਗਏ ਨੇ, ਪਰ ਉਹਨਾਂ ਕੋਲ ਵੋਲੰਟਰੀ ਸਪਰਮ ਡੋਨਰਸ ਨਹੀਂ ਹੈਗੇ। ਸਪਰਮ ਡੋਨਰਸ ਨੂੰ ਲੱਗਦਾ ਕਿ ਇਹ ਪ੍ਰਾਈਵੇਟ ਹਸਪੀਟਲ ਹੈ, ਇੱਥੇ ਸਾਡੇ ਤੋਂ ਤਾਂ ਫ੍ਰੀ ਵੋਲੰਟਰੀ ਡੋਨੇਸ਼ਨ ਮੰਗ ਰਹੇ ਨੇ, ਅੱਗੇ ਆਪ ਪੈਸੇ ਕਮਾਉਣਗੇ। ਤਾਂ ਜਦੋਂ ਇਹ ਹਸਪੀਟਲ ਏਮਸ ਵਰਗੇ ਤਾਂ ਗਵਰਨਮੈਂਟ ਹਸਪੀਟਲ, ਮੈਡੀਕਲ ਕਾਲਜਾਂ 'ਚ ਜਦੋਂ ਬੈਂਕ ਖੁੱਲ੍ਹਣਗੇ ਤਾਂ ਲੋਕ ਖੁੱਲ੍ਹ ਕੇ ਆਉਣਗੇ। ਜਿਵੇਂ ਏਮਸ 'ਚ ਲੋਕ ਆਪਣੀ ਬੋਡੀ ਡੋਨੇਸ਼ਨ ਲਈ ਵੀ ਪਲੈਜ ਕਰਕੇ ਖੁਦ ਅੱਗੇ ਆ ਰਹੇ ਹੈ। ਉਹਨਾਂ ਨੂੰ ਲੱਗਦਾ ਹੈ ਕਿ ਗਵਰਨਮੈਂਟ ਹਸਪੀਟਲ 'ਚ ਹੋ ਰਿਹਾ ਤਾਂ ਕੰਮ ਐਥੀਕਲ ਹੋਏਗਾ, ਵਧੀਆ ਹੋਏਗਾ, ਸੁਸਾਇਟੀ ਦੀ ਭਲਾਈ ਲਈ ਹੋਏਗਾ। ਤਾਂ ਬਹੁਤ ਵਧੀਆ ਹੋਏਗਾ ਕਿ ਜੇ ਆਪਣੇ ਇੱਥੇ ਵੀ ਸੈਂਟਰ ਖੁੱਲ੍ਹਦਾ ਹੈਗਾ, ਇੱਥੇ ART ਬੈਂਕ ਖੁੱਲ੍ਹਦਾ ਹੈਗਾ ਤਾਂ ਸਭ ਲਈ ਬਹੁਤ ਅੱਛਾ ਹੋ ਜਾਏਗਾ ਔਰ ਮਰੀਜ਼ਾਂ ਲਈ ਬਹੁਤ ਅੱਛਾ ਹੋ ਜਾਏਗਾ। ਉਹਨਾਂ ਨੂੰ ਘੱਟ ਪੈਸਿਆਂ 'ਚ ਨਿःशुल्क भी सर्विसेज अवेलेबल हो जानी चाहिए।
थैंक यू डॉक्टर।
थैंक यू।
और अभी हम बात करेंगे, आओ सर आप। सर कॉपर सर्जिकल जो कि फर्टिलिटी सॉल्यूशंस के लिए एक बड़ा नाम है और आज आप लोगों ने यहाँ पर साथ में मिलकर ऑर्गेनाइजेशन में बहुत ज़्यादा बड़ा हिस्सा डाला, क्या कहना चाहिए?
ਸਰ ਸਾਡੇ ਲਈ ਵੀ ਬੜੀ ਮਾਣ ਦੀ ਗੱਲ ਹੈ ਵੀ ਏਮਸ ਵਰਗੇ ਰਿਪਿਊਟਡ ਇੰਸਟੀਚਿਊਟ ਸਾਨੂੰ ਇਹ ਮੌਕਾ ਮਿਲਿਆ ਆਉਣ ਦਾ। ਡਾਕਟਰ ਰਜਨੀ ਜਿੰਦਲ ਬੜੇ ਸ਼ਹਿਰ ਦੇ ਬੜੇ ਮਸ਼ਹੂਰ ਇਨਫਰਟੀਲਿਟੀ ਸਪੈਸ਼ਲਿਸਟ ਨੇ। ਫਿਰ ਉਹਨਾਂ ਵੱਲੋਂ ਮੇਰੇ ਕੋਲ ਇਨਵਾਈਟ ਆਇਆ ਜੀ ਅਸੀਂ ਏਮਸ ਦੇ ਵਿੱਚ ਇੱਕ ਪ੍ਰੋਗਰਾਮ ਕਰਨਾ ਚਾਹੁੰਦੇ ਹਾਂ, ਸਪੈਸ਼ਲੀ ਉਹਨਾਂ ਪੇਸ਼ੈਂਟਸ ਵਾਸਤੇ ਜੋ ਕੈਂਸਰ ਤੋਂ ਪੀੜਿਤ ਹੈ। ਉਹਨਾਂ ਨੂੰ ਇੱਕ ਆਸ ਦੀ ਕਿਰਨ ਦਿਖਾਉਣੀ ਹੈ ਵੀ ਜ਼ਰੂਰੀ ਨਹੀਂ ਵੀ ਜੇ ਤੁਸੀਂ ਕੈਂਸਰ ਤੋਂ ਪੀੜਿਤ ਹੋ ਤਾਂ ਤੁਸੀਂ ਅੱਗੇ ਮਾਂ ਨਹੀਂ ਬਣ ਸਕਦੇ ਜਾਂ ਤੁਹਾਡੇ ਵਾਸਤੇ ਰਸਤੇ ਬੰਦ ਹੋ ਗਏ। ਉਹਨਾਂ ਰਸਤੇ ਨੂੰ ਖੁਲਵਾਉਣ ਵਾਸਤੇ ਅਸੀਂ ਇੱਕ ਛੋਟੀ ਜਿਹੀ ਪਹਿਲ ਰੱਖੀ ਵੀ ਐਟਲੀਸਟ ਅਸੀਂ ਇੱਕ ਅਵੇਅਰਨੈਸ ਕ੍ਰੀਏਟ ਕਰੀਏ ਆਪਣੀ ਗਾਇਨੋਕੋਲੋਜੀ ਫਰਟੀਲਿਟੀ ਦੇ ਵਿੱਚ, ਐਜ਼ ਵੈਲ ਐਜ਼ ਉਹ ਬੱਚੇ ਜੋ ਹਜੇ ਯੰਗ ਪੜ੍ਹ ਰਹੇ ਹੈ ਉਹਨਾਂ ਲਈ ਵੀ ਬਹੁਤ ਜ਼ਰੂਰੀ ਹੋ ਜਾਂਦਾ ਹੈ। ਇੱਕ ਮੈਡੀਕਲ ਤੋਂ ਬਿਨਾਂ ਕਿ ਜੇ ਆਪਾਂ ਨੂੰ ਸੋਸ਼ਲ ਰੀਜ਼ਨ ਵੱਲੋਂ ਵੀ ਵੇਖੀਏ, ਹਰ ਇਨਸਾਨ ਕਿਸੇ ਨਾ ਕਿਸੇ ਕੈਂਸਰ ਪੀੜਿਤ ਨੂੰ ਜਾਂ ਕਿਸੇ ਨੂੰ ਜਾਣਦਾ ਹੈ, ਚਾਹੇ ਉਹ ਸਾਡੀ ਰਿਸ਼ਤੇਦਾਰੀ ਵਿੱਚ ਹੋਵੇ ਜਾਂ ਸਾਡੀ ਦੋਸਤੀ ਵਿੱਚ ਹੋਵੇ। ਐਟਲੀਸਟ ਉਹ ਇੱਕ ਅਵੇਅਰਨੈਸ ਜਿਹੜੀ ਪਬਲਿਕ ਅਵੇਅਰਨੈਸ ਬੜੀ ਜ਼ਰੂਰੀ ਸੀ, ਉਹਦੇ ਵਿੱਚ ਇੱਕ ਸਾਡੀ ਇਹ ਪਹਿਲ ਸੀ ਵੀ ਅਸੀਂ ਇਹਨੂੰ ਅੱਗੇ ਲੈ ਕੇ ਆਈਏ ਅਤੇ ਸ਼ਾਇਦ ਉਹ ਮੈਨੂੰ ਲੱਗ ਰਿਹਾ ਵੀ ਅਸੀਂ ਉਸ 'ਤੇ ਥੋੜ੍ਹੇ ਖਰੇ ਉਤਰੇ ਹੈਗੇ।
थैंक यू। आइए।